Hello everyone. So today I'm back with a new video and the topic for discussion is antenatal corticosteroids. So many times we think when should we give it or not, and how many courses to give. So today it's time for all our doubts to get cleared. So why delay? Let's move on to my today's agenda. So I'll be covering in the following headings: the introduction of why corticosteroids is important and how does it act, mainly the mechanism of action, and what drugs are available and what is recommended, what is the dose and route of administration, and at what gestational age antenatal corticosteroids are actually recommended, and what is its use in late preterm and early term deliveries, and rescue doses versus repeat doses, and special considerations in some conditions like multiple pregnancy, PPROM, and what are the main side effects. And we all know in worldwide, 10% of the babies are born preterm, and the respiratory distress syndrome is the most common cause for both mortality and morbidity in preterm babies. So antenatal corticosteroids help in reduction of this respiratory morbidity, mainly the respiratory distress syndrome and other complications associated with a preterm birth. So as we see in this picture, the antenatal corticosteroids are among the low-hanging fruit in the management of preterm delivery and labor. So in this cases, antenatal corticosteroids, when indicated, if we give, so we can cause the reduction of respiratory distress syndrome as much as 30 to 50%. And this was proven by the Cochrane collaboration also by various meta-analysis. So these are the different conditions which the antenatal corticosteroids will help with. So there is reduction of neonatal death by 31%, RDS by 34%, intraventricular hemorrhage by 45%, necrotizing enterocolitis by 55%, and overall NICU admissions by 20%, and early systemic infections by 50%. So that is why it is very important and it's a need of the hour to decide and give antenatal corticosteroids whenever we encounter a preterm birth. So we definitely have understood that it is important to prevent RDS. But how? So that we have to understand. So how does antenatal corticosteroids prevent RDS? It is mainly that it prevents the collapse of the alveoli and helps in the expansion. So it prevents atelectasis and development of hyaline membrane disease or respiratory distress syndrome. So it causes an irreversible cytostructural maturation at the level of the type 2 pneumocytes and the lung alveoli. So it accelerates the development of type 1 and type 2 pneumocytes, and we all know type 2 pneumocytes help in the production of surfactant, and it also increases the saccular and alveolar gas volume, and it decreases the alveolar septation. So these are all at the level of the cells, and because of this physiological changes which occur and cause increase in the surfactant production, and it acts on the beta receptors to absorb the alveolar fluid which is excess, and it also has an antioxidant property which helps in the lung protection, and also it helps in gene expression for epithelial sodium channel, and this also helps in the fluid resorption. So when the fluid is resorbed and the alveoli expand, this helps in gaseous exchange and it prevents respiratory distress syndrome. So this is the main mechanism of how the antenatal corticosteroids induce lung maturation. So less than 34 weeks, we know that the lungs are not matured enough and there is no adequate surfactant. So that is why we recommend antenatal corticosteroids. And I will be discussing about the exact gestational age which is recommended by various guidelines and what is the present consensus about the delivery and timing. So now coming to the drugs. So there are two types of drugs. One is the betamethasone and the dexamethasone. These two drugs are recommended for the pulmonary lung maturity. So these are available in different doses and routes. So we have to always prefer a route of intramuscular injection. Oral and intravenous are not recommended. Why? Because intravenous administration of steroids will not have a steady plasma concentration. So there is increase in peaks and troughs in the maternal circulation. So this will not help in the fetal lung maturity. So that's why the preferred route is intramuscular. And now which drugs? So this betamethasone is available and we have to give in a dosage of 12 milligram 24 hours apart, 2 doses. And dexamethasone 6 milligram 12 hours apart, 4 doses. So I will repeat, betamethasone which is given in a dosage of 12 milligram 24 hours apart, 2 doses. Dexamethasone 6 milligram 4 doses and 12 hours apart. So this is the recommended course of the antenatal corticosteroid. So this is the dose and this is the drug. Now we have to know which is more preferred, whether it is dexamethasone sodium phosphate or betamethasone. So previously, when the studies were conducted, this betamethasone, which is in the form of both acetate and phosphate mix, was used, and then they told that this drug given in the dosage of 12 milligram 24 hours apart for 2 doses is enough, and this causes the same maturity as the dexamethasone 4 doses. But what is available in India and many more countries, this premix or the betamethasone acetate phosphate combination is not available. So the available combination is only the betamethasone phosphate. So this betamethasone phosphate, if given in the same dosage course, this will not have that much efficacy. So it requires more frequent administration. But because it is the premix or the mix of acetate and phosphate combination is not available, and we are using the same course for betamethasone phosphate, the efficacy is questionable. So that is why the preferred drug of choice is dexamethasone. And we all know dexa is much more cheaper when compared to betamethasone, and it also can be stored in room temperature, whereas betamethasone has to be stored between 2 to 8 degrees Celsius. So the preferred drug presently in India is dexamethasone sodium phosphate, which is given in 6 milligram for every 12 hours for 4 doses. But sometimes we do not have the 6 milligram ampule. So we take the 4 milligram ampule and we give 1.5 ml. So 1 ml contains 4 milligram. So 1.5 contains 6 milligram. So we have to give 6 milligram for 4 doses 12 hours apart. And also in GTG, that is in RCOG GTG, they have also told that dexamethasone has slight more chances of decrease of intraventricular hemorrhage when compared to betamethasone. But for decreasing the lung maturity or decreasing the respiratory distress syndrome, both are equally efficacious. But with respect to intraventricular hemorrhage, dexamethasone is even more effective when compared to betamethasone. So that is why presently dexa is preferred over beta, especially in India. So timing. So there are different guidelines. So we have RCOG, we have GTG, we have Cochrane review, and we have other FIGO guidelines, FOXY guidelines. So there are different clinical practice guidelines which tell what is the timing for the antenatal corticosteroid administration. So we have to decide when to give. So the ideal timing is between 24 to 34 weeks of gestation. Why 24? Because that is said to be the period of viability. So after 24 weeks and up to 34 weeks is according to ACOG guidelines. But according to RCOG guidelines, they tell 24 to 34 plus 6, that is almost up to 35 weeks. So we have to offer corticosteroids between 24 to 34 plus 6 weeks of gestation. We can consider corticosteroids between 35 weeks to 36 weeks, 6 days. That is late preterm. So we have something called as early preterm and late preterm. So early preterm is less than 34 weeks and late preterm is more than 34 weeks. So we have to offer in early preterm and we have to consider in the late preterm category. But definitely there is reduction in respiratory distress syndrome given in this time period. So even in late preterm, it is better to offer corticosteroids because the risk benefit ratio, the benefits are more when compared to the risk of single course of corticosteroids. So the time is presently by ACOG is 24 to 33 plus 6 weeks, that is 34 weeks, and when there is risk of imminent preterm delivery by the next 7 days. So in the next 7 days, if you're anticipating preterm delivery, so in cases of PPROM or induced preterm birth or in cases of severe preeclampsia or FGR, so all these cases, if you're planning the preterm delivery or already she's in spontaneous preterm birth or she's a cases of PPROM, so in these cases, there is a risk of preterm birth in the next 7 days. So whenever this risk is present, it is always better to give antenatal corticosteroids. So ACOG recommends between 24 to 33 plus 6 weeks. But what does NICE recommend? It also recommends between 24 to 33 plus 6 weeks. But the present GTG recommends between 24 to 34 plus 6 weeks of gestation. That is 35 weeks of gestation. So this is the preferred timing or gestational age when we have to give antenatal corticosteroids and when we are anticipating the preterm birth to happen in the next 7 days. So before going to the role, so then I have to also tell you that if she's already in preterm labor, if she's around 2 to 3 centimeter dilated and you're anticipating her delivery within the next 24 hours, should you give antenatal corticosteroids? Yes, because the benefit even if given less than 48 hours is also beneficial and it reduces the complications of preterm birth. So if the preterm birth is so they tell that the corticosteroids take at least 48 hours for it to act after the given the last dose. But still, if you are anticipating a preterm birth by 24 hours, it is always better to give a single dose at least before she delivers because there is slight benefit when compared to the risk. So we can give any time between 24 to 24 hours to 7 days when we are anticipating a preterm birth. And how many days of action it has? So it takes around 48 hours to 7 days to the complete cause of lung maturity or pulmonary maturity. So this is the amount of time it requires for complete action. So next coming to what is its role in late preterm? So I told it has to be considered. So the word offer means you have to give. There is no doubt in it. So it is a must give option. But consider is you can consider giving because the benefit overweighs the risk and it is also the clinician's discretion. So even in the late preterm category, that is between 34 weeks to 36 weeks 6 days we can still consider to give antenatal corticosteroids, and early term that is after 37 weeks it is not indicated as such in a spontaneous vaginal delivery, but in elective cesarean delivery even done between 38 to 39 weeks of gestation, according to the GTG, we have to give a course of antenatal corticosteroids. So, because the babies who are born over a cesarean birth have higher chances of transient tachypnea of newborn, respiratory distress syndrome, admissions to NICU, need for ventilatory support. So, all these are increased in the babies which are born out of a cesarean delivery because the lung fluid is not expressed as such because there is no pressure during extraction. Whereas in the normal delivery, when the baby is passing through the birth canal, the lungs or the chest is squeezed so that the alveolar fluid comes out so that the babies born from a normal vaginal delivery have decreased chances of respiratory distress syndrome when compared to the babies who are born by a cesarean delivery. So that is why even in elective cesarean delivery done less than 38 weeks, 6 days or 39 weeks, it is better to give a course of antenatal corticosteroids. A single course is more than effective to prevent all these complications. Next, coming to, I told you one course. So what's one course of antenatal corticosteroid? Is just one course, that is dexamethasone 6 mg 12 hours apart, 4 doses. Betamethasone 12 mg 12 hours apart and for 4 doses. So betamethasone is 2 doses, dexamethasone is 4 doses. So this is a single course of antenatal corticosteroids. Do we require multiple courses of antenatal corticosteroids is a question mark. So there were many studies which were done, like ACTOD study, MAX study. ACTOD study actually told that we can give a repeat dose or repeat course of antenatal corticosteroids if the previous course of antenatal corticosteroids have given more than 2 weeks. So it has been 2 weeks since the last course and the gestational age is less than 34 weeks of gestation. So I will repeat, if the gestational age is less than 34 weeks and it is almost 2 weeks elapsed after the last course of antenatal corticosteroids, we can repeat the course of antenatal corticosteroid. So it decreases the RDS and it decreases the duration of mechanical ventilation. But the only disadvantage is there is slight decrease in the weight and head circumference at birth. And long-term complications, there might be little higher chances of attention disorders in the childhood. So this was the conclusion by ACTOD study. But no consensus has proved that more than 2 courses of antenatal corticosteroids in any condition. So it is either 1 or 2. If the second course has to be given, it should be more than 14 days of the last course and the gestational age should be less than 34 weeks. So this is called the repeat dose. So what do we mean by a rescue dose? So rescue dose is a single dose of corticosteroid which can be given if the gestational age is less than 34 weeks and it is 7 days elapsed from the last course. So if there is 7 days after the last course and still the gestational age is less than 34 weeks, we can consider to give a rescue single dose. So repeat dose means the entire course, but the rescue dose means a single dose. So I hope this is helpful and you have understood what is the difference between rescue dose and a repeat course. So what are the special considerations? So do we have to give antenatal corticosteroids in cases of PPROM? Yes, definitely, because PPROM has higher chances of going into preterm labor. So pre-PPROM, the longest distance which can go is the latent period. It could be around 32 to 35 days, but most of the pregnancies by 7 days they go into spontaneous preterm birth. So it is always better to give antenatal corticosteroids in cases of premature preterm rupture of membranes. So next, what about multiple pregnancy? Even in multiple pregnancy, the role of corticosteroids is clear, but the dose, course and duration, everything is as same as a singleton pregnancy. But still, we have to give and consider to give antenatal corticosteroids because even in multiple gestations, the chances of preterm birth is high. And if we are anticipating a preterm birth in the next 7 days, it is always better to give. And the dose schedule is same as a singleton pregnancy. Next, what about diabetes mellitus? Either over diabetes or gestational diabetes, we have to give antenatal corticosteroids because this is not a contraindication for administration. We all know that corticosteroids increases the maternal blood sugar level. It causes maternal hyperglycemia. But we have to adjust the doses of insulin if she is on insulin or start insulin if she is not on insulin during this period of giving administration of corticosteroids. So how many days it will take for the blood sugar level to come back to its normal? It is between 2 to 5 days. By 2 days, there is peak of the blood sugar levels on the third and fourth day, and by fifth day, the blood sugar level will come almost back to normal or the pre-antenatal corticosteroid administration level. So we have to give corticosteroids, but we have to add insulin or increase the dosage of insulin accordingly. So what are the side effects? So we all understood the benefits of corticosteroids are so much that we have to definitely give in cases of preterm birth. But we have to also know what are the side effects. As such, there are no much side effects, but it has proven in some studies that there might be decrease in birth weight if the birth occurs after more than 7 days after corticosteroids. And sometimes there might be some behavioral changes in late pediatric age group. And one very important thing is there is slight increase in neonatal hypoglycemia. So because it causes maternal hyperglycemia, the chances of neonatal hypoglycemia is more. So that's why if the baby is born, we have to encourage exclusive breastfeeding and monitor the GRBS of the preterm babies because there are higher chances of going into neonatal hypoglycemia. And also sometimes when we administer in a planned cesarean birth, as I told you, between 37 to 38 plus 6 weeks of gestation, there might reduce some amount of IQ reduction might be there. But this is all seen only if multiple doses of corticosteroids are given. There might be changes in the neurodevelopment pattern and cognitive impairment. But only with 1 or 2 courses of antenatal steroids, there are no long-term proven effects or consequences about this. So that is why only 2 courses are recommended and not more than that. So we have understood that the importance of corticosteroids is too much in the obstetric practice, and presently as there are both maternal and fetal risk factors, the chances of preterm delivery have increased and there is more prevalence of preterm birth, both elective preterm birth and spontaneous preterm birth. So giving antenatal corticosteroids is the need for the hour because there are so many benefits. It's not only that it decreases only respiratory distress syndrome, the chances of overall neonatal morbidity and mortality are reduced after the administration of corticosteroids. So we have to understand that this is very important and we have to identify a preterm birth or an imminent preterm birth and give steroids, and DEXA is presently preferred in a dosage of 6 mg, 4 doses, 12 hours apart. I am telling it multiply because it gets reinforced, and it has to be given at least between 24 to 34 weeks of gestation. And the other things I have told clearly in the video. So these are my various references, both RCOG and GTG mainly, and ACOG also. So we have to administer antenatal corticosteroid whenever we are encountering a preterm birth. So this is the take home message. Thank you. Happy learning.